Hi, everyone. This is ToRAISE Questions Doula podcast, and this is Thérèse Hakoun, and I am Executive Director of To Labor, which is an international doula training and certifying organization. So here I am, not with Melanie once again, but she'll be back. I am in the studio by myself, and today is one of those kind of cloudy, rainy, cool spring days, and I'm kind of loving it, and it feels cozy in here, though it would be nicer if I had company. But soon I will have company as far as being able to converse with a wonderful doula from Seattle, Jocelyn Alt, who we're going to have a conversation about a hospital doula program that she initiated and has been moving forward for a little while now. And it's going to be a great conversation, I believe, about what it looks like, how it started, all the details I hope we can get about this. So I'm looking forward to talking to Jocelyn. Just always a reminder to you, to everyone who's listening, that we have our website, tolabor.com. Please check out our information, who we are, what our intention is behind our trainings, what we offer, and the calendar where we're having workshops. You know, we don't have a zillion workshops going on, hardly. We have always every year between 12 and 24 workshops. We limit our amount based on keeping a quantity, more a quality of intent in that quantity of workshops. So check out and see if there's something in your community coming, or in a nearby area, or a place that you thought, ooh, I'd love to see what Albuquerque, New Mexico looks like, and what a perfect time to go to Albuquerque, but in October when it's just spectacularly beautiful. Consider traveling if that is a possibility. And as always mentioned, if you are interested in potentially seeing if we can have a workshop in your community, contact our workshop coordinator at tolaborworkshops@gmail.com and get information about what that looks like, what the responsibilities are, what To Labor's responsibilities are back to support you, and see if that's a workable situation for all of us. So I'll be back in a moment to start our conversation with Jocelyn. Hi, everyone. So we're back. I'm here with Jocelyn Alt. Hi, Jocelyn.
Hi, Thérèse.
How are you today?
I'm doing really well. How about you?
I'm good. I don't know what the weather is like for you where you are, but the day for me is rainy, and it makes me think of your area.
Yes, you would be correct today. We've had a couple of days of sun, and we're back in the rain.
Yeah,
so.
It's rainy and cool here, but I kind of like it. I'm kind of enjoying it. I wouldn't want it every single day, though. That's my
We're
thing.
used to it.
Yes, I know. And you're in such a beautiful environment. I guess it balances itself out.
Absolutely.
So I would love to start talking about the program that you're involved in. But first, I want to just give you an opportunity to tell all of us a little bit about you, who you are, how you came into doula work, and anything else you want to add into it, your background.
Great. Well, my career has really been on two parallel paths, one of them being health policy and the other one being doula work. So early in the around 2005, 2007, I worked in the Massachusetts state legislature, and the state was doing healthcare reform under Governor Mitt Romney. So I really learned health policy there and became the chief of staff of that office.
Wow.
And thought about becoming an OBGYN and doing policy and medicine as sort of a dual career. So I took my pre-med classes at night, and then I found out about doulas. And I thought, oh my gosh, this would be amazing experience as I thought about going down the OB path. So that was when I signed up for your training. I took it in beautiful White River Junction in Vermont, drove up 2006. And I thought the training was just incredible. I learned, of course, about the birth process, but really, to me, that cracked open the appreciation of birth as a rite of passage, and really the opportunity that the doula has to help that be a time of empowerment for a family. So I moved to Washington, D.C. I got a job working in Congress there on national healthcare reform under Obama. And, contrary to sort of media portrayals, the Romney care and Obamacare are pretty much the same thing. So they were interested in someone who had the experience in Massachusetts. And then while I was there, I've always been really passionate about social justice, and I got involved with the DC Family Health and Birth Center there.
Great place.
Which is an amazing place.
Yeah, really.
Started by Ruth Lubeck, serving 95% Medicaid, 95% African American. And I, with another doula, started a volunteer doula program there. So that was kind of my first organizational role in doula work. And we had anywhere from 40 to 60 doulas at a given time. We did shift work as well as the relationship model of care. And then I moved to Chicago. My full-time job was working at Blue Cross Blue Shield there, but I joined an organization called Chicago Volunteer Doulas,
which is
and was on their board.
Excellent program.
Wonderful organization. Really amazing group of people too. That worked in 4 hospitals in Chicago, mostly again with lower income clients. And then the two paths kind of converged for me, the policy and management and doula work in 2012. And I decided I'm going to do doula work full time now. So I left Blue Cross Blue Shield and I started my own company called Ohana, which means family in Hawaiian. My sister lives in Hawaii. And the idea behind it was really to have a company that had full wraparound services. So I had doulas on the team, but also childbirth teachers. We had parent groups. We did sleep coaching, just lactation services, a variety of things for expecting a new parent. And when I moved back to Seattle, I started another branch of it here, and the path kind of coincided with Swedish Hospital when they put out an RFP looking for someone to help build a doula program. And I think because of the experience I'd had in these various contexts, ended up being awarded that RFP, and that's kind of where my involvement began. Wow.
What is so impressive is the crossing over, as you said, of your policy work into this really important field of health. I mean, it's all important, every field of health, but since it begins at birth, what a great opportunity to be such a part of it and use those skills. I mean, I almost feel jealous, like, oh God, I wish I were you, Jocelyn. I wish I knew all the information you have behind you. Just that's crazy. Though then again, I was never cut out for probably that kind of work. I mean,
I've been really fortunate.
Yeah. And I think it's great how it's taken you from Massachusetts down to DC to Chicago, and now you are in the Seattle area, which is just amazing.
And I grew up here, so for me, this is wonderful to come home.
Gotcha. And do you have any children of your own?
No, I'm actually expecting my first baby.
Oh.
So when I get out of breath, because my lung capacity for talking is about half.
Isn't it crazy now? Isn't it crazy?
Yeah, so many changes, and it's just so wonderful. I mean, I've been a doula now for, I guess, around 11 years, and now going through it for the first time myself, it's pretty special.
Yeah. So when are you due around?
June 28th is my due date.
Great. Well, wonderful. That'll be, it's, my input to you, take it or leave it, is, and it'll be somewhat hard, is you got to turn off your doula brain when you're in labor. You know, you've got to turn it off now, but you got to turn it off.
That sounds like good advice.
Yeah, when you're in labor, I hope whoever is with you can help you remember that, because it's really hard when you know as much as you know to not analyze your labor and your birth. But if you have people around you that you trust, they're going to be the ones who are going to be doing that left brainness for you, and you can just be in your right brain and have a baby. So
that sounds like great advice. I'll tell my two doulas that what you said at our next meeting.
Yeah, I think that's good. So you've got two who are going to be rapping on one ear and the other. Stay right here, Jocelyn. Don't try and be a doula to yourself. So what evolved with this program, which is at Swedish Hospital? How did this come? What was their motivation for wanting to start a doula program? And then how did you get it going? And what are the, all the parts of it?
Yeah. So they have two really amazing leaders in women's health here. And I think that's what really initiated it. They have an administrative director and then an executive director who is an OB, maternal fetal medicine doctor herself. And they really spearheaded this initiative. They had done a kind of full department strategic planning meeting and looking out at the different opportunities in the marketplace and also just for improving women's care, and really looked at the research and said, wow, doulas improve outcomes and they improve experience. We should be incorporating this as a more integrated part of families' labor and delivery.
Right.
So they were really
they were looking at the evidence and deciding, let's base our practices on the evidence. Oh, evidence-based practices. I get it. Got it.
Yes. Yes.
True, it's true.
And so, and so that's when they started working on it and ultimately put out the request for proposals, as I mentioned, for someone to come in and help them build it. And
so what happened? Did they have a vision? Did you have the vision? How was this all transpiring?
Yeah. So I submitted a proposal. The way that it is constructed, and parts of this were things that I proposed and parts of it were things that I developed in concert with those two leaders. And then the woman who is my co-manager now, who was the project manager when it was getting initiated as well. So we decided to structure it as an independent contractor relationship. And part of the impetus for that was to try to maintain really the primary accountability to the client. I think that's one thing that people sometimes get concerned about with a hospital-based program, where is the doula accountable to? Mm-hmm. And so that was part of that decision-making process. The other piece of it is that from a management point of view, myself and my colleague, Kelly Ryan, are what we call a dyad here. So we co-manage the program. The doulas report to me as an independent contractor and to her as an employee. And so there's this kind of separation of, the doulas are not reporting up through some medical chain of command.
Got it.
And so we have about 40 contracted doulas, and we have both certified doulas and what we call apprentice doulas who are working on certification. The clients, hospitals' patients, but we call them clients still because, of course, we're not medical.
Right.
They select their doula. We operate only in a relationship model of care. So the client gets the 1 to 2 prenatals, labor and delivery, and the postnatal from that one doula they've chosen. The client pays the hospital directly, and the hospital retains a portion of that payment for administration and also for a fund that we created. And this was part of my proposal in the spirit of social justice, and something that Swedish also embraces very strongly, a fund for free care for low-income clients who can't afford it.
So which is wonderful. So can you say how much? Is it a percentage or is it a flat fee that is kicked back into this administrative and scholarship funding?
Yep. So it's a percentage for the certified doulas, which is 25% of the fee.
Okay. And
the doulas they choose their own rate, and some of them bumped their rate up to accommodate that 25%. Some of them decided that they would keep it the same because they would be getting more volume, and that's been the case for most of them. So they kind of decided how to manage that for themselves.
And then if you aren't certified, it sounded like there's a different percentage for the apprentice or the ones who are working forward.
The apprentice gets a stipend. So they get a flat rate and we retain a flat rate, and that goes to the same fund, but also it goes to mentorship from one of the certified doulas for them.
So explain that a little bit more. So the flat fee, is the flat fee decided by you all?
Yes.
Okay.
Mm-hmm.
And what is that? Do you mind mentioning what that is?
That's $200.
Okay, so it's $200, and then they get that full $200?
They get the $200, but the client pays $500.
Okay, so the client pays $500, and the $300 goes back into the scholarship, the administrative, and does it go to a mentor, did you say, as well?
Correct.
Okay, so a certified doula would go to the birth with them?
So the required parts of the mentorship are checking in around each client touch point, and then when feasible, either the mentor attending the birth with the mentee or the mentee shadowing the other doula.
Okay.
Certified doula.
And then how long are you in the apprentice in that role?
We started it out that it was not time limited, and basically whenever you got certified, you would just move into the certified and pick your own rate and move into that model.
Okay.
We changed it this last go round so that it's now 6 months, a 6-month period.
And do they have to have had a certain amount of births in that 6 months?
No. One interesting thing we've found is that in our area, at least, I don't know if you have national data on this, that on average it takes a doula about 2 years to get certified in the Seattle area. Our apprentices are averaging about 6 months to get certified. And
is that because they're being given the opportunity in these births to be able to get their certifying births?
That's what most people are hypothesizing, that
right.
Yeah.
What if they're not, so how does the program work as far as the client? So somebody wants, a patient of the hospital wants to have a doula.
Right.
What's the process for that person to choose a doula? How do they?
Right. So that person calls the doula office, and myself, or we have an operations coordinator, takes their call. And we ask them a number of questions to try to get a sense of which doulas on the team might be a good match for them. Like, we'll ask them if they have any particular personality characteristics in a doula they think might be a good fit. You know, some people want someone really more calming. Some people are looking for someone with that pizzazz and energy to keep them going, or special skills like hypnobirthing or additional breastfeeding certifications, and then experience level and cost. So those are kind of the main areas that we ask them. And then we check the doula's availability for their due date, and we send them a number of suggestions based on that conversation. And then we have a place on the Swedish Hospital website where the doulas have profiles.
Right.
And they take a look at those and they let us know which ones they want to interview.
Over and above perhaps the ones that you suggested.
Sure.
Okay.
Yeah, we can let them know whether those are available.
Right.
And then we send emails connecting that patient with the doula to set up the interview.
Got it. Okay.
And they typically will interview, between 1 and 3, and then make their choice. They can interview as many as they want, just like they would privately. And
do patients because I'm referring to them as patients because they're not the client at that moment of a doula. I'm talking about patient of the hospital. If somebody is pregnant, how about that? And they see, oh, there's a doula service program at Swedish. They can just go on the website and contact those doulas directly, or do they always have to go through your office?
They can. Yeah, the names are there. We don't list the contact information on the website,
okay,
but they could easily, Google the doula if she had her private business and contact her directly.
Right. But if they did get the work, the doula, in that process, they still have to give back 25%. Is that correct?
That's correct.
Okay. If there's any contact with Swedish, then they have to give that fee. Do these doulas also work independently?
Yes.
Okay.
They're not limited in any way from doing births at other hospitals or birth centers or home births.
How about,
and those would just go through their own business.
Right.
Without
and same thing
anything.
with if they had a client who was independent of Swedish but was birthing at Swedish, like they got their name through somebody else, a referral, a friend, a family member, or doulamatch.net or something like that, however the person has advertised themselves. And they contacted a doula who also provides services to Swedish, but these people end up birthing at Swedish. Is there any conflict there? Is there any fee?
All people delivering at Swedish, no matter how they contact, go through the program.
Okay. Got it. So I to clarify that, I got it, and then watch, I'll say it wrong. If I am a doula who works, I'm on contract work with you, but I get a referral from somebody and they want to birth at Swedish, I'm still obligated to Swedish to provide that 25%, and that client will pay through Swedish's system.
Correct. That's how the contract is written.
Okay. So how do you decide? You said you have 40 something. What did you say? How many doulas?
Mm-hmm. Yep. 40 contracted doulas.
And how did they come to be? So the process of finding a doula as a patient or as a potential client, we heard that. What if you are a doula and you think, oh, I would love to be a part of this program or be a part of a program like this? What is the process for them?
Mm-hmm. So we've had 3 rounds of hiring so far. In the first round, there was a lot of community information that we had to put out.
Right.
Because this is brand new. We had in our area a volunteer program at a hospital, but we'd never had a paid program at a hospital. So we just did a lot of outreach. I think that's something that we found was really important in terms of being really transparent and getting all the information out in the community, really connecting with a lot of the leaders in the doula community here, and explaining what we were trying to do and the goals of the program, and the model that we were going to build. So we disseminated it through the information through a variety of channels. We had an open house in person. We had an online open house through the Penny Simpkin Center at Bastyr University. And that's how doulas initially heard about it when we first started, through one of those efforts.
Okay.
And then we had an application process. So they applied to the program. They all had an interview, and then we selected the ones we were going to offer contracts to from there.
And therefore, from that, what is implied to me is that not everybody who filled out an application got offered a position.
Correct.
Okay, so I don't know if this is even possible, Jocelyn, but maybe even as one example, what was the criteria? How did you decide who was the fit and who wasn't the fit?
So I think one of the guiding principles that we have we had a set of values that we established at the very beginning of the program. And I think that was really helpful from a variety of perspectives. They were similar to the ones that I had developed for Ohana. And, Ohana is the company contracted to provide the service of building the program here at Swedish. But those were helpful from a perspective of guiding how we built the program, but also very much in terms of how we built the team. So there's 3 categories in the values: 1 toward our clients, 2 toward medical practitioners, and 3 toward Swedish doula team members. And, for example, the ones under clients is that we honor our clients' journey as their own, providing information without judgment and believing in their innate intuition and making their own decisions. So I think that there are some doulas that come at the work from a different perspective than that. For example, they have a particular philosophy about how birth should go, based on any number of their own life experiences or perspectives. And so those people weren't a great fit with what we were creating. Another example would be under medical practitioners that we adhere strictly to our scope of practice. We don't speak for our clients to medical practitioners. These are things that are in the scope of practice of a doula, right, for many of the certifying bodies. But, there are some people, again, who may not practice that way. Right. So those were things as well. And
then the last value was towards each other.
And that's really about being a community together, doulaing one another, and wanting to be in a team environment.
And so you said that, which I'm really glad, I should comment on that. I'm really glad that you have that as the criteria, and it's so clear cut, like, okay, and you're listening, I guess, in those interviews very intently with those things in mind about how they're going to fit in to be able to do that. Is it availability also at all?
We have actually taken that into account more as we've gone on, because of course, managing a person is managing a person from an HR perspective, all the paperwork and, just time. And so if a person can take 1 birth every couple of months, it's the same management as if they are taking 4.
Right, right.
We did later take that more into account. Yes.
Yeah, I would think so. I just for the reasons that you're saying, you're making a commitment to them as well, and want to see a return, in essence, on it as well. You said that the doulas can set their own fees. So what is the range of the fees, would you say, of the doula services that are being offered?
We did bucket them into 4 bands for simplicity's sake. So we have 4 bands they can decide upon. It's $800, $1,200, $1,600, or $2,000 for the certified doulas is the rate that the client pays, and then the 25% comes out of that.
Right. And do you find, is the 800, maybe you don't know clearly the answer to this. So if somebody's charging 800 and someone's charging 2,000, is there a difference in their experience? What is the difference that they charge, $1,200 more or less?
It is mostly experience where people kind of bucket themselves there. Yes. Okay. So it tends to be number of births, but then there are certain things, like if someone is a massage therapist as well, or a certified lactation consultant, they might, put themselves in a higher category for one of those reasons.
Right. And include that in their fee. I know that you've talked about the scholarship program, which wasn't initially there for the lower income. Are there doulas that will just offer services for less than that, or do less than the 800 for lower income, or would somebody then receive the referrals for the apprentice ones if 500 was what they could afford?
Right. So if the client, we started the subsidized program this January. So we had been going for a year. We actually had a committee of doulas that decided how that was going to be structured. So doulas who are contract with the team decided how that was going to look.
Okay.
And what they determined is that the doulas who would be serving, so these clients, the subsidized service is for any patient who's on Medicaid.
Okay.
So that was our criteria.
Okay. Anybody who's on Medicaid would qualify for the subsidized.
Free. Yeah.
And it's
so
free.
It's free to the client.
Okay. Free to the client. Okay.
But we pay the doula.
Okay.
Through that fund.
Okay.
We're one of our guiding principles has been, just as an aside, we really believe that doula work is high value, and we were committed to having our program be paid across the board,
which is wonderful. I mean, and I hear how it's working because in essence, the client is paying. It's like being independent, except it's serving a bigger cause, a bigger picture. And I agree. I mean, this is the conversation is volunteer is wonderful and it is no less valuable. It's just, and so we encourage it, for those who can afford to do that. But yes, we support that you are so valuable. This work, your services are so valuable. Charging for it is good and right. But there is always that feeling of there are people out there who cannot afford this, $800, forget it. Anything higher than that, no way. And so that's the hard part is the people, everyone deserves this and everyone could benefit from this. So I'm really glad to know there's you have a program in place. So what would a doula get paid if she is taking on the no cost, the subsidized client?
Yeah. So the apprentice gets paid the regular $200 stipend, and the certified doula gets paid $600.
Right. And are they required to do a certain amount of those births, or is it just if they choose to, they can be a part of it?
It's their choice. Okay.
So no stipulation around that. So the program was started the initial program in January of 2016, correct?
Right. I came on in October, so we had a 3-4 month build, and then we launched in January. And
so initially it was you were getting doulas by your outreach. Now you said you've had 2 rounds of interviews. How many did you start out with?
Let's see. I think we started out with between 30 and 40 at the beginning.
Okay.
And then we've had doulas who have gone to school or gone on maternity leave or
just for numerous reasons.
Am I remembering that correctly? Maybe it was fewer the first round. Maybe around 30.
Okay.
Sorry, I can't remember exactly.
Yeah, that's okay. And so then is there a number, is 40 like your max, or is there a number, will it be higher at some time?
It just depends on the client growth, really.
So let's talk about the client growth. What are you seeing as far as how many births take place at Swedish Hospital a year?
So we have, sorry about that.
That's okay.
I don't know how to silence that.
Yeah.
We have 4 campuses.
Okay.
So we have 12,000 births annually at the 4 campuses.
Okay. And at this point in your first year, how many of those births were attended by Swedish doulas?
So in the first year, the doulas attended 340 births.
Ah, that's I know that's a small number in comparison to 12,000, but that's really a great start, I think. What was your feeling? What was the group's feeling?
Absolutely. We were very pleased with the sort of interest and And one thing that's really neat is that we survey all of the clients after they get their service. And one of the questions that we ask them is, would you have hired a doula if this service wasn't offered through the hospital?
Good
and
question.
What we found is that 46% now say they would not have hired a doula.
Wow.
If it wasn't through the hospital. Yeah.
Wow, you mean because what is the takeaway from that, Jocelyn?
Well, I think it's a couple things. One thing we hear from clients is that having the programs through the hospital, I think it's two things. One is that it introduces the concept as something that's sort of more mainstream than some people would have thought previously. Some people have a sense that doulas only do home births, or they have this misinformation.
Right.
And so for it to be offered through the hospital, I think opens up the option as something to consider for a segment of people that had misunderstandings about what a doula is. The other piece of it is that we get quite a lot of feedback that the process of being able to go through the program office and have these doulas that have been vetted,
right,
takes a lot of the intimidation and sort of overwhelmingness. That's not a word, but
no, but I like it. I use it.
Out of the process for them. The fact that there's someone they can talk to, give them recommendations of people who might be a good fit, and that they know that they've been vetted. Those are really the two things we hear.
Yeah, and I could see whether this is right or wrong is irrelevant. I can see where it gives to some people more credibility and more feeling of safety, security around it as well. Right. Like you said, it's vetted. It makes the process less complicated. And I guess also for people, I would assume of that 46% that you said it was,
yeah,
that a percentage of those 46% never even heard of a doula before.
Exactly.
Yeah, that they would not have even known that was even a possibility for them because they weren't aware of it. I mean, we know doulas are so much more in the mainstream than it was 11 years ago when you took the workshop, but right. That still there are people who just don't know it, and yes, may have the misconception of what a doula actually does, including that they're not just there for those who want low intervention births in the hospital.
Absolutely.
Yeah, that you're willing to, whatever your desire is, you can still have a doula and really benefit. So how does speaking of that, if somebody has a doula and is planning a cesarean, or their birth unfolds and the labor unfolds and the birth outcome is going to be necessitated by having a cesarean, is the doula present for the cesarean?
That's a great question. And that's something that evolved in a way that we were really excited about once the program started. At the Swedish hospitals, there's been differing policies and implementation of policies about whether doulas can be in the operating room over the past few decades. Mm-hmm. And one of the things that was really neat that came out of starting the program here is that we got clarifications and some changes to policies, a number of things. So one is that the doula doesn't count as one of the 3 visitors. And this goes for both doulas contracted with Swedish and independent doulas.
Which is great.
Yeah. So that was important to us too, that there wasn't a distinction. That they can be present during the placement of an epidural, which was not always the case.
Right.
That they can be present in the hour after recovery of cesarean. And then to your question, that at the discretion of the anesthesiologist for, whatever their medical reasons might be, that the doula is present in the OR.
So would you say, and that's kind of, we're always, I know where I am, it's and in other parts of the country, we're always told that it's really the anesthesiologist who has the call on the situation.
Right.
Yet my experience has been that I've never had a conversation with the anesthesiologist if it was okay or not. It's just if the doctor and the nurse and everyone feels like, oh, this has been working, we go on in. But I understand that they have the right to refuse in
Right.
essence for a doula's presence there. So what would you say? Do you know the statistic of how many cesareans that have taken place? Do you know how many doulas have actually been present?
Oh, your mind works exactly like mine because we just added that to our birth report survey.
Oh, maybe
So
I have a future in policy.
Yes.
No, but not yet. But in the future. And what about statistics also that you'd like to share? Like, are you seeing through this a reduction in certain interventions that, you can see from the year before, years before that have changed in any way, whether it be epidural use or instrumental delivery, cesarean, hospital stay, any of those things?
Yeah, well, one of the neat things about being integrated in the hospital is that we have access to the full OB data team.
Right.
So that's been really great for a policy wonk like me.
Yeah.
So we do. We pull those down for comparing doula cases where we have had a doula to ones where there isn't. And thus far, we do see reductions in the things that are in the research. So we see reductions in epidural use. We see reductions in cesarean rates. We see reductions in NICU admissions. Their challenge right now is that the numbers aren't high enough in terms of, we've now had over 500 births attended by doulas on the team, but even with that, given the large number in the system, we don't have statistical significance around a number of those.
Right.
So we can't yet publish the exact numbers, but we're seeing the trends very similar to what's in the published research.
And so what is the hospital's feeling about the program? Was there, Jocelyn, a timeline given to you like this is a project, it's a project program for X amount of years, and then we'll re-examine if this continues, or what was the beginning in that way?
It wasn't framed that way, really. And I think this speaks again to the leadership of those two directors, where they said, this is something we think is important. We're going to start it assuming we can make it work. And I mean, I think we really have exceeded their and the senior leadership's expectations or hopes for it. So that's been really great, just in terms of the interest that we've had, the feedback from our patients. I mean, for our clients, our satisfaction, again, we ask people, the average is 4.9 out of 5.
Wow.
So
that's excellent.
So we're just, I think they've been really pleased with how it's gone.
And so is the hospital, I mean, I guess this is a little too early, what you're saying, it's too early at this point. They can't quantify this quite yet financially? Right.
No, I mean, that's a hope, and it's a hope too in terms of making a case down the line to insurers. Absolutely.
Right.
But we have to really wait till that statistical significance, at least from the outcomes perspective.
Right. Well, we had the conversation with Everyday Miracles organization recently on the podcast, which is the program out of Minnesota in Minneapolis.
I listened to that one. That was a great
and just what episode. A great program. And they're not integrated into the hospital, but doing a similar thing, except for it's volunteer, except for that they do get reimbursed the Medicaid. But the numbers were there as far as the state seeing the cost effectiveness of a doula by the cesarean rate reduction and the
so terrific.
Yeah, so wonderful that, I think the trend will continue to be that way. Unfortunately, that the stipend, in essence, that the doula is getting for those births is not a living wage. I mean, it's under $500, so
Right.
it doesn't really make it sustainable. And the program in Oregon, if I said it then, and I haven't looked into it, but my understanding that it was only $50, which obviously is not, that's paying for parking for the day and maybe a cup of coffee. So
Right.
I hope I like your program where it's accessible to everyone, and there's a system, and the doulas are getting paid. And yes, they may have to give money to Swedish, but it is like a finder's fee. And their name is always going to be out there. And what a great way to continue to just have the opportunity to take on births. What a great way. And then the subsidized births, yes, that's not a living wage what they'll get, but it's not free either. I mean, they're not doing it for free. And
right.
Which is wonderful. What is the hospital staff, the doctors, the nurses, the midwives' response to the program?
Yeah, it's been really positive overall. I mean, we also survey the nurses and the providers, and in the high 90s, they say that we ask them two questions. Do you think the doula had a positive impact on the patient's experience? And would you want to work with that doula again?
Okay.
So, simple questions.
Yeah.
To both of those, we get responses in the high 90s that they say yes.
That's
to each
good.
of them.
Well, that's really good. What if they didn't have a positive experience with the doula? Not that the client didn't, but that the staff didn't. What is there what do you call it? Oh, is there a process? That's not the word I want to use, but
we do. We have a feedback process.
Okay.
So, and that happens. That has happened certainly a number of times. And what's nice about being so integrated is that we have relationships with, there's so many providers. There's, over 300 nurses and OB just at our main campus, and 150 doctors and midwives. But we have relationships with many of them. It's, again, one of the things that's really strong about having this dyad of myself and Kelly, who is a Swedish employee, has been an employee for a long time, has really deep relationships. That when that happens, there's a dialogue that occurs, and
including the doula.
Yes. It depends on the scenario,
right.
Just different things. But yeah, right. We all sit down together, try to get to what the conflict was. One of the things that was so interesting is that there were a lot of questions that nurses had. So when we started the program, we had these donut meetings. I would go to the 7 a.m. Shift change and just answer questions. And I really feel like some of the nurses had been bottling up their doula questions for like 30 years.
Probably so.
And just never had someone in front of them to ask. So I would get these questions like, is it normal for a doula to sleep? Right. To them, being on shift, that to some of them seems so bizarre. They would never sleep during a shift in the room.
That's such a good, yes. Well, I totally understand that nurse's perspective if she felt like the doula wasn't doing her job.
Right.
Well, doing her job well, if that she saw that, I was sitting over on the couch asleep right at that moment, sitting up, laying down, but my client was asleep also. I guess even still, it would feel like, why are they sleeping?
Exactly.
Yeah, because of the perspective. And, the workshops are about that, are us understanding each other's perspective so we can work collaboratively together. So, yeah, what a great
And being able to clarify that.
Yeah.
I know this doula may have been at that client's home for a huge chunk of hours. It's our commitment to our clients that we are there with them continuously to the very extent that we can. So if they do sleep, it's a way of us upholding our commitment to them to also take our rest, and just increasing that understanding.
That's great. And so I guess, yeah, there's always going to be those moments when people don't see eye to eye on things. But if you're getting 98% saying that they liked, that it was a positive experience one way or the other, I mean, that's pretty darn high.
Mm-hmm. And it speaks to the selection, too, we were talking about. I mean, the doulas that we brought on, they're people who want to work in a collaborative way with medical providers. Right. Do the doula, so what is the doula's perspective of working in the system and their feelings of how it's working for them? Yeah, so with my research hat on, I wish that we had these data. We have a student from a nearby university who's going to be doing a survey of our doulas to get more quantitative data, like how did their income, our sense is that people's income is going up because they're getting fuller bookings. Many of them are charging more. But things like, so anecdotally speaking, one of the things that I hear from the doulas is that there's real benefit to them in the cohesiveness of being part of the hospital. So I'll give a couple of examples. One doula had a client who had a crisis, and she was concerned about harming her baby. She was pregnant and harming her own baby, and she called the doula. The doula has that type of trusting relationship where She was the one the client reached out to. But the doula said, gosh, that is outside of my scope. I don't know what to say to that person. So she called me. It was late at night, and I reached out to the inpatient social worker team here. I have access to their phone numbers through the hospital system. And we were able to get her input on what needed to happen with that client. It turned out the recommendation was to come to the emergency room for that type of situation, and get the help there. But that's an example of that integration allowed us to care for that client.
Right. Without the doula stepping outside of her scope of practice, or at staying within her scope of practice, but being able to still support the client really well with a different resource or the right resource.
Right. And another one, a mom, expecting mother, found out that she would need an induction very soon, that day, and that her baby was likely to need to go to the NICU. So that was all new information. She was feeling very anxious about it, and particularly not being familiar with the NICU protocols and policies and how it was set up. And so, again, the doula called, and we were able to connect that mother with a NICU staff person within the hour to talk her through. And they offered to do a tour. She could come in and privately look around and just get a sense of the space. It's just things like that really
which would be
ability.
Yeah, I think that is wonderful, because though that would be available, there's that direct line. It's like that truly collaborative care, almost that one-stop shopping kind of thing. Like, okay, you hire me and I may not be skilled at all of these things, which is what we doulas should put out front right away, and should have good resources. But within the system that they're working within, the resources are there, which is wonderful. Wonderful.
Right.
What have you seen, if any, I'm sure, were the hard parts about this, or the downsides of it, or the glitches that you ran into that you weren't anticipating?
Yeah, so I would say one of the big ones is how hard communication is in a large hospital system. And I mentioned, with 300 nurses at our main campus, hundreds of doctors and midwives have privileges at the fore. Getting information out is really hard. And particularly, for example, on those policy changes and clarifications, we worked with the right management. We let the doulas know, but then they were still being applied very haphazardly. And there's frustration there for the doulas who are saying, look, this was changed and clarified, and the nurse or other medical person at the bedside is saying, well, I never heard about it. So that's really a challenge.
Yeah.
How to get out information and communicate.
And you're working on solutions, obviously, to that somehow.
Yeah, it's a constant process.
Yeah.
It's really just figuring out new ways that those, early shift change meetings I mentioned was a big one of those. Because we could talk with 20 nurses at a time. We would bring donuts and hope more would come.
Yeah. Have there been unexpected outcomes that you weren't anticipating? In the positive sense, I guess.
Let's see. Well, I guess there were just so many unknowns.
Yeah.
We didn't know if doulas would apply.
Right.
Was really...
How many do you think applied initially, Jocelyn? I mean, you hired 30 to 40, whatever the number was initially. You can't remember exactly, but how many would you say actually came forward? Would you say 50, or was it?
Let me see. I'm just opening up my files here.
Mm-hmm.
There were, looks like about 50 applied, and then about 30 were accepted.
Yeah. And then since then, and you've done the rehiring the second and third time around, are you getting more people interested who want to apply?
Yeah, we've got, I would say it's about that same proportion.
Yeah.
But we've hired fewer, but yeah.
Right. Well, that's really good. And you know that it will just probably increase as the program continues to grow. And, I'm sure there's lots of doulas out there who also don't know about the program they may have heard of it, but don't know much about it, or haven't heard about it because they're in their own little world of doing their work. And then we know there's always new doulas being trained constantly, and those dropping in and those dropping out, and all the things that.
And we're really fortunate in our area. I mean, we have very robust training programs.
Right.
Here. So, and they're, very frequent trainings. So certainly our apprentice program. And I think that was another thing, just to put a note on that, is that one of the things that I had identified really in my work previously is that there's a real challenge for many people getting from training to set up as a doula.
Yep.
And that the timeline, the differential in the timeline to certification speaks to it, but also we offer monthly team meetings and trainings, and those are open. Well, they're required for all the doulas that are on the team. And we did do a quantitative survey of how the doulas, the value they felt they got out of those, and they were rating them about 8.5 out of 10 as far as what that was providing to them. So those are free.
And what would be some of those workshops or classes or gatherings be about?
Yeah, so a couple that we had one on going more into depth of supporting pregnancy with multiples.
Okay.
We had one on supporting clients with a baby in the NICU. We did a neat one. We have an institute here that does simulations where they have a room that looks like a birth room, and they have, actors who were previous medical providers, and you act out a scenario. We did that.
That's good.
We had one on recently. We had two full day trainings that were, again, free to the doula on the team on serving clients experiencing addiction, recovery, and incarceration.
That's great.
And we had one on supporting families in grief. So there's a couple of examples.
Oh, that's great. And that's all free for those who are in your program,
right.
Which is, their money coming back to them,
Mm-hmm.
that free training.
Exactly.
That's free training. Do you feel like your energy's still fresh into this, Jocelyn? Like this is something you're moving forward with yourself?
I have been I just feel really fortunate to be a part of it. I feel really excited about the fact that it's something that's fairly uncommon still.
Yeah.
And I think there was a paper that tried to count the number of hospital-based programs, and I think among paid programs, there were only about 10 or 12 in the country based on her research. So I feel really energized by it. I think, again, because I'm an independent contractor, I have the ability, if there's other hospitals that want to do it, to contract with them and build at other places. And I would love to have that opportunity if others came forward.
Yeah, I think there's nothing like having someone like you who has walked already. It's like that same thing of that cliche or whatever it is, where why are we trying to invent, a new mousetrap when you already know how this mousetrap works really well, starting from scratch. There's such wonderful, like you mentioned, the Chicago volunteer doula program. They're a great example of a very successful volunteer program.
Right.
You're chalking up right now numbers that look like a very successful paid doula program. And what really is nice about it for, a hospital is they really don't have any out-of-pocket expense on this. They're reaping the benefit of it, but the clients are the ones who are paying. It's just under their system, and they're providing the willingness for this to occur. But it's almost like, well, why wouldn't they want to do that?
Right.
What is the liability issue for the doulas? Do they have to have liability insurance?
Yes.
They do.
Mm-hmm.
So they have to have a liability policy to cover, so that the hospital is, but they're subcontractors, so they're not employees anyway of the hospital, and the contracts, like they must have. The clients must have contracts with the doulas, just like we would want doulas to have contracts with any client.
Yes, we call it a client services agreement because contract means something specific in the hospital.
Right, right.
But yes, we have that with each client.
That's good. And the doulas do, and the one thing that some programs have that it appears from our conversation you all don't have, there isn't a training program in Swedish that is training the doulas. They get training from independent training organizations.
Correct.
Yeah. Was it ever a consideration to do your own program for training?
It was discussed, but very quickly determined not to be a part of it, in part because, as I mentioned, we have such strong training programs in our area.
Right. And then you've got people who move to the area who have been trained by, organizations as well. I guess it makes sense. And if somebody is interested in being part of the program, they must go through, I assume, a doula training program first before they would be a candidate.
Yes, there's one thing to note there, which is another piece that we started that I'm really excited about. This was initiated by some of the doulas on the team. We have a scholarship program for doula training through the hospital, and this is funded by our community benefit department. So we approached them and proposed this, and it's a doula diversity scholarship. And it's geared toward getting more doulas of color and doulas from LGBTQ community and people from other underrepresented groups into the profession. And so, through that, people can apply to that scholarship without having done the training, obviously. And then the scholarship pays the full cost of the training, full cost of certification. We have a lending library, so they don't have to pay the cost of books. And they also get a mentor who's one of the Swedish doulas.
That's great. Wow. And was that always a part of it? But it sounds like no. It sounds like it was initiated somewhere along the line.
Yeah, it got initiated around 9 months into it.
And you said who pays for that? The hospital community?
The hospital community benefit departments. There's a department in the hospital that's basically the philanthropy arm of the hospital. No.
And I would assume most hospitals have something like that as well. Some form.
Yeah, I guess it's more outreach,
right?
Community outreach
right.
dollars.
Right. And languages.
Yeah.
What about that?
We have 9 languages among the doulas on the team currently.
Wow.
Mm-hmm.
Wow. That's great.
Yeah.
Wow.
And then we're hoping to get more through the scholarship.
Yeah, that makes such a difference. I mean, it makes such a difference in these conversations that I've had with the, in Minneapolis, and the one that I had with the woman in Pennsylvania of needing more people who can speak the language of those who English is not their first language. How important. I mean, I always think of this, like how hard it is for anyone to be able to communicate and clearly when you're in labor in this country, but not to speak the language is just, I just can't imagine what that is like.
Right.
So what a great gift. What about, is one of the languages ASL or the...
We don't have ASL yet.
Mm-hmm.
Yeah, that would be one to add.
Yeah, that would be one to add. So those who are listening, if that's your specialty and you live in the area, you should consider becoming, when the next round. How often do you do interviews?
We do them 3 times a year.
3 times.
So we just did our second one, and we have the next one in October.
Next one in October. Well, Jocelyn, this has just been such a lovely conversation. Thank you so much. I feel like it's inspiring, it's exciting, and it's answering my dream of everyone deserves a doula. And I know that it's just putting it out, when you do have it a part of a system, not that I think this is the only way to go by any means, but it does make it more noticeable. I mean, it's more, people see it. They see it and they go, oh. And I know there's still so many people who feel like, well, if my doctor said or the hospital recommends, then I should look into this as well. And so it really just gives a broader light. And I love that if anyone is on Medicaid, which, I mean, how does that work out? Because 60%, I think, of those who are birthing in this country are on Medicaid currently.
Yeah, I mean, we use all the money we have above administration for that.
Right.
But it's not unlimited.
Yeah.
And the more that our paid side grows, the more that
will
fund
grow
grows.
too. Yeah, which is really wonderful. Well, when we put this up on the for publication, there will be some resources mentioned on our page about this program and the contact information. If this is something you're interested in, if you're in the area, obviously check it out, or thinking of moving to that area. But also if you're just interested in potentially seeing if this is a program that somehow you could get started in a hospital in your community. And it sounds like, Jocelyn, you're the perfect resource. As you said, you're a private contractor, so Ohana can contract with people to be able to maybe initiate these programs, which would just be wonderful, just wonderful. So
absolutely,
I really appreciate it. I remember you clearly in 2006. That was a great setting, like you said, White River Junction, Vermont. We were right there at almost in New Hampshire. I think we went out to dinner in New Hampshire, a bunch of people, and here you are, skipped across the country again.
Can I tell you one thing from that training, Thérèse, that
Sure.
I have said so many times to other doulas and has helped so many? I don't know if I've ever mentioned it to you, but It was something that stuck with me that I remember frequently in these past 11 years. You said that if you were allaying, I think, some anxieties of us new doulas coming out of it fresh. And you were saying, if you go into a room, a birth room with an open heart, that family's experience will be better because you're there.
Oh, I truly still believe, it gives me kind of chills because I still truly believe that. I still say that. I think there's absolute truth in that. And I'm glad that you heard it. I'm glad you're passing it on because, yeah, if we come in with a compassionate heart, an open mind, and a focus in that person, of course, that experience is going to be a better one. I mean, I know that from my own life experiences. So I'm really glad you're passing it. I'm really glad you're making this happen and making doulas more accessible to so many other people. So it's been lovely talking to you, Jocelyn. Thank you so much.
Thanks so much, Thérèse. It was a pleasure.
Take care of yourself.
You too.
Okay, bye now.
Bye.
Well, that was a great insight for me. I hope it was for all of you. I can't imagine that it wasn't. It is inspiring. It is a potential. It's a possibility for many of you out there to potentially start a dialogue, a conversation with hospitals. Talk to Jocelyn through Ohana and see if this is something you feel could work in your community. I mean, I see just so many positives to it and really not, at least from this conversation, downsides to it. And I just see hospitals really benefiting from being able to advertise that they have doulas in their that they support doulas and have a list of doulas to recommend to their patients, their customers, and it seems like it works very well for the hospital clientele, and it seems it works well for the doulas. So I'm sure there can be criticisms about it. Perhaps if I think much, in detail, there are more things that I might question and wonder about. But overall, I would say it's very, very positive and gives me, I said to Jocelyn, it gives me hope. It makes me happy, it fills my heart, and it gives me hope. So there are going to be resources for you to check out if you go to our podcast page for this episode 110. We'll put up the contact information about the program and some of the things we talked about. So I hope everyone takes care of themselves. Always, always remember the caretaker is often the person who needs extra care. So remember that. Reach out and let other people take care of you as well. So we'll be talking to you again in the near future. Bye now.